Okay, so as I said, the project we're talking about is the dyadic impact of social care for older carers and the people they support, which we've abbreviated to the DYADS projects. So I'm Stacey Rand, I'm the PI, Principal Investigator on the project, but I've also got the project team colleagues here with us today. So everyone is here with us apart from Helen, who will be joining us, Helen Ramsbottom, who will be joining us later. And also, unfortunately, Christina Redding couldn't be with us, but the rest of the team is here are at the event and will be able to answer any questions that you have. So just to acknowledge that this project was funded by the School for Social Care Research. What we're presenting are our findings and views as the researchers and authors on the project. And also to emphasize today, these are preliminary findings. So some have already been published, but others are emerging findings from the study. So you get to hear about them first. And also, I think importantly, not on the slide, but to say a huge thank you to everyone who supported the project in various ways. Those who've participated, who've been involved in discussions about it, and everyone who's shown an interest, and including all of you listening. So to give a little bit of an overview of what we'll be talking about over the next hour and a half, the project was in 3 strands or work packages, and we'll be taking each one of those one by one and giving a little bit of an insight into what we did, why we did it, and what we found. The first work package will be presented by my colleague Wenjing, which was a literature review. The second one was around interviews with social care professionals, which I'll be presenting. Then we had interviews with older carers and the people they support, or DYADS, which my colleagues Barbara and Grace will be presenting. And then at the end, colleague Alison will be giving a short reflection on the findings and an opportunity for questions and discussion. So a little bit of background around this project. So our focus was older carers aged 65 and over. And when we're using the word carer, we're thinking about family carers, unpaid carers. And the reason we took this focus is we know that this group of carers is growing. We think there are at least 20% of carers in the UK. There was some evidence during the pandemic that there was a swelling of this number. We're waiting to kind of see the latest numbers from the recent census so that we get a bit more of an idea of exact numbers, but we know that they're a significant group. We also know that older carers have specific needs. They're more likely to be caring for someone who's co-resident with them and to have their own health and social care needs. And we also know that community-based social care, whether that's home care, day activities, or other kinds of support, all play a role in supporting people, improving their quality of life and well-being. And that often the view of those services is about supporting individuals, but particularly when it comes to older people, older carers, there's a question around how do we not only support people as individuals, but support people together, improving and supporting their well-being as a unit. So the aims and objectives of this study were to ask some of these questions to understand how services do support the quality of life of older carers and the people they support, both as individuals and together. Also to spend some time thinking broadly around the benefits and challenges of applying what we call a dyadic lens. So where we're thinking not just about individuals, but thinking about them in relationship, particularly the relationship between the carer and the person they're supporting. And also trying to draw out what might be key learning that can be applied in policy, commissioning, service planning, and also care practice. And as I mentioned earlier, we have 3 work packages or 3 areas that we looked at using different methods. And we'll, in the next series of 3 short talks, we'll go through each of those in a bit more detail to share what we did and what we found. So I'm now going to stop sharing these slides and hand over to my colleague Wenjing, who will be talking about the first work package, which was a scoping literature review.
Thank you, Stacey. I hope my slides is popping up in front of you all. Hello, everyone. I'm Wenjing. I'm going to present our findings from the first work package, which is the literature review. On behalf of the team, and for our review, we had the question focused on to identify and summarize what is already known about the quality of life of older carers and the people they support, consider them together, which we refer to as dyadic quality of life. We looked at how do older carers and care recipients experience quality of life from a dyadic perspective in general, and also with regard to the impact of community-based social care. We conducted a quite comprehensive search as shown in this flow diagram. We searched 16 databases and lots of websites of, for example, charities, government, and other to look for grey literature. However, as you can see, through the process of reviewing, we reviewed those identified over 800 items based on the criteria of focusing on older carers and care recipients from a dyadic perspective and their quality of life or well-being. Through that, only 14 papers were identified as relevant to the topic, and we further analyze them thematically, which I will present the findings from that shortly. This table presents the main characteristics of the included 14 studies. As you can see, the country context spanned 3 countries if they were relevant to specific countries, 6 in the UK, 3 in the United States, and 1 in China. And also there were quite a few 4 literature review papers. They considered international studies, so had a very wide approach there. And from the reference type, the majority of them were journal articles, 11. We also included 1 PhD thesis and 2 research reports. And included studies applied a variety of designs. Some of them, like 5 of them quantitative studies, 5 literature reviews, several qualitative studies, and 1 applied mixed methods. For our findings, we presented them under 2 themes. The first is kind of what is the overarching approach to understand dyadic quality of life from the existing studies outside there. And the second is what these included papers, or some of them, how do they highlight the role of support from outside of the DYADS, like from family, friends, and neighbors as unpaid care, as well as from community-based social care services, and how do they promote and impact quality of life outcomes of older carers and people they support. So for our first finding topic, several studies included in our review draw upon an overarching theoretical framework. We call it as interdependence theory in understanding dyadic quality of life. This framework kind of suggests that the relationships are defined through the interpersonal interdependence. For example, in the caring relationship, people interact between each other, and one other's experience, health situation, emotional states, thoughts, attitudes will also impact on each other's quality of life and other outcomes. As this diagram here, we adapted based on Stacey and other colleagues' previous work called actor-partner interdependence model. For example, the carer's characteristic, it can be, for example, carer's health situation. It could impact their own quality of life, which is the line of the parental line, carers' quality of life. At the same time, it might also impact on the quality of life of care recipients, people they support. So it will be the partner effect there. It is vice versa, it's the same care recipient situation could impact, and it will be a mutual influence between the quality of life of care, if my mouse is working there, between carers' quality of life and care recipients' quality of life there. In addition to the impacts or effects between them or within the dyads, there are also more wider contextual factors that impact on carers and care recipients' quality of life. For example, their external other family members, the wider community support, economic background of the family, and so on. So this is kind of represents the model to say how the interdependence are being identified from the caring relationship. And also there were many included studies. They highlight the dynamics of caring relationships and also the mutuality and the interdependence of people in relationships by their intimacy, affection, or dependence. For example, it's highlighted that caring always takes place within a relationship, and the existing relationship can most of the time shape the caring experience. And at the same time, or likewise, caring also shapes the existing relationship. Also, there were some studies that refer to existing or developed existing theories, for example, about social exchange theory, which highlights that people seek to maximize mutual rewards arising from relationships and interactions, and especially an equity theory, which is closely linked to the above, also highlights the importance of equality and mutuality in dyadic relationships. And when they talk about caring relationship, they especially highlight the interactions or social exchanges from a lifelong perspective. It's not only at the caring stage, it's also from their relationship and the interactions before caring and looking ahead for their long-term perspective for the relationship. At the same time, some studies highlighted the conflicts or tensions within caring dyads. For example, it can take in a number of different forms. People with support needs might have limited power in some situations and feel obliged to give control to their carer, but at the same time, the care recipient, carers, they might also take control in the ways that might not make the people they support feel comfortable enough. In some cases, some studies highlighted that care recipients can also push back against this situation and create difficulties in the caring practice. So it's quite in different forms identified by different studies about the relationship and different forms of relationship and interactions within the caring dyads. Our second theme, as responding to our second review question about the wider support that influence the dyadic quality of life. First, about the support from families, friends, and neighbors. It's very common that other family members provide support and impact the quality of life of older carer and the people they support. And also, friends and neighbors commonly act as supplementary assistance for the dyads in their daily life. Also, there were several studies highlighted the impact of community-based social care on quality of life of care and diets, and they found mixed evidence of the impact. For example, some studies found there are a few joint and individual interventions that targeted to the diet or to individuals. They can be very effective. For example, couples counseling, music therapy as targeted to the diet. And also the most common one about individual service that impact on both quality of life is respite care for carers. It can improve or impact on the quality of life of both the carer who use the services and the people they support. However, there are many either they titled as dyadic interventions or it's just normal interventions targeted to one group. They didn't take into account of the relationship factors when design and deliver the services, and most sometimes neglect the interpersonal issues about the quality of their relationship and the importance of making the communication between them. So it's kind of can be a few studies reported that especially care recipients' views tended to be overlooked in those situations. And also a few studies mentioned that the dyadic approach are being recognized by some social care practitioners and providers about the importance of adopting a dyadic approach to needs assessment, reviews, and care planning, which I believe Stacey and other colleagues will talk more in their findings from the interviews from our study as well. So the key messages from this review is really these studies jointly emphasize that the importance of considering the quality of life of carers and care recipients together would potentially improve the understanding of care needs, provision, and quality of life outcomes of carers and the people they support. However, as I mentioned earlier, there's very limited numbers of evidence outside there about dyadic quality of life and the impact of social care services. So hopefully future work would explore more about the dyadic approach in social care practice and research. And I'm sure you will find more interesting approach being applied in practice from our interview findings. So that's all from the review work. And any questions, also you can email me for further questions and check our website there. I'll stop sharing and bring back to the question slide.
That's great. Thank you very much, Wenjing. So we have a couple of minutes now if there are any questions based on what Wenjing's just shared. If anyone does have a question, then please do raise your hand or put it in the chat. That's great. I can see a few comments coming in. So from one, thanks Wenjing, really interesting. Did the studies included in the literature review focus on dyads of carers and spouses and quality of life?
Thank you for the question. It's a very interesting one, Gillian. So we included in our inclusion criteria for any caring relationships, as long as it's older carer and people they support. And from the 14 included studies, we did have quite a few. I'll bring the numbers in front of me about spouse relationship, but also there were some relationship about supporting adult children. And let's say the caring diet here, we had 2 studies were diets with older carers exclusively, and 2 were about mixed diets of spouse, parent, siblings, friends, or other diets, because some studies they consider different caring relationships. And Also, there were some studies about focus on older carers supporting people with dementia and spousal dementia diets and disabled older people and their carers diets. So it's the studies, although it's only 14, but they consider quite a variety of different caring relationships.
Okay, thank you, Wenjing. So at this stage, we're going to move on to the second work package, which I'll be presenting. So I'm just going to open up the slides again. Okay, so I hope everyone can see the slides. Good, I've got a nod. Okay, so I'm going to be presenting on the second work package of the project. So if we go back to the aims and objectives, the second one was around the benefits and challenges of applying what we're calling a dyadic lens. So thinking about the way in which support can improve quality of life, not just of individuals, but also in relationship, and thinking of people as units, not just thinking of individuals in isolation, but also in relationship. And in this second work package, the method that we adopted was interviewing social care professionals. And we actually spoke to 25 professionals, all based in England, working in a variety of roles. So that included commissioners, social workers, managers, people working in a variety of organisations, care providers, carers organisations, and other third sector organisations. And everyone who took part agreed to participate in an interview, a semi-structured interview. And that interview covered two main topics. The first one was around thinking about that person's role and their professional experience. How were they using what we call outcomes data in their practice? And so just to define, when I'm talking about outcomes, I'm particularly thinking of things that capture or measure quality of life and well-being, although we did in those conversations look at some other definitions or ways of thinking about outcomes. But for this study, we were especially interested in quality of life and well-being. And the second half of the interview, we were then taking that initial thinking around outcomes and then thinking around people's experience, also perceptions of the benefits, challenges and barriers of applying what we're calling a dyadic outcomes approach. So not just looking and being interested in one person's quality of life, but also being interested in two people, particularly thinking around the carer and the person being supported. And so here is just to sort of emphasize, because I know that this concept can be a little bit difficult to get your head around, but once you've got it, hopefully it's quite straightforward. And I know many of you working in the sector will know a lot about outcomes, but what we're really thinking around is quality of life for people with support needs and also family carers. And keeping that focus on quality of life is really important, because people want to know, people who are delivering services or commissioning them or managing them want to know what difference they're making, and not just for one person, but also the other people who are close to that person. So what did we find? Well, thinking initially about using outcomes in practice, we got a whole range of different views and experiences about how outcomes are being used. And we found that they're there in needs assessment and care planning, which we wouldn't be too surprised about, given that that's often embedded in the way that people work. But also it's there in service delivery, planning, and also in-house evaluation, trying to work out how well services are doing. And they're also used in contract management and commissioning. And we found a range of different ways by which outcomes are captured and recorded. And that ranged from validated questionnaires. So what I mean by that is a series of standard questions that people are asked to fill in, either on their own behalf or on behalf of someone else. And this way of collecting information was quite helpful, because it meant you could collect the same information from a large number of people. You could then pull that together and it would give you an overview of what was going on. And you knew that when you were looking at that data, it was all, you were able to bring it together. So you were looking at the same thing, you were not comparing two different things. But we also found that in practice, there was also other ways of collecting outcomes, and that was perhaps in conversations or by developing case studies. So this was perhaps with a smaller group of people going into much more depth, trying to capture something around the context and that person's narrative, and also the complexity and change over time. And to give a few examples, sometimes in needs assessment, for example, there would be a more open conversation guided around certain outcome topics, but also in providers trying to show the impact of what they were doing, they'd maybe pick a small number of case studies and develop those and write them up with quotes and pictures to really bring that alive. So those are the two main ways that data was being collected. And in talking to professionals, they were able to articulate a number of benefits of using outcomes. A key one being understanding the effect of services, and particularly the effects on supporting people to live well as they wish to. And really nice quote here. So from a commissioner, a focus on outcomes really brings to life the impact the services are having on people's lives and helps to bring that story of why there's an ongoing need for services, particularly in the time we still live in a time of austerity. So something about capturing what's going on and showing the value of what's being done. But there were also a number of challenges and barriers. A key one that came up a few times was around asking the right questions in the right way. So a couple of quotes here. The questions aren't relevant. They don't capture the work we're doing with that person from a care provider. So sometimes the particular service and what's being done and the questions being asked of people using the services to try and work out the effect, they don't actually align. And also another thing that came up a few times was that some of the questions being asked were actually seen as invasive. And that actually it could be viewed as intrusive or sometimes upsetting for certain questions to be asked in a particular way. And with that second quote, you can see there was a kind of preference for a focused conversation approach that could be adopted and used in a gentler way, navigating around people's needs and emotional states as they are navigating perhaps quite difficult situations in their lives. Other challenges and barriers included the ability to capture what we call contextual influences on outcomes. So the quote here, what they're not seeing with outcomes data is that when you're working with carers, their scores might go down because their caring role has changed. So what's being tapped into here is that someone's quality of life may go up and down for a whole number of different reasons, particularly thinking around carers. There might be situations going on that have an impact, a negative impact, that's nothing to do with the support or the service. And yet the drop in outcomes data might be seen negatively as reflecting on the service when actually there's something else going on. And as I mentioned earlier, the case study approach, or perhaps even when you're collecting quantitative data, if you can use statistics in the background, there are ways of capturing the context, but often they're not applied in the way that outcomes are used in practice. Another point was the sheer volume of data being collected and shared. I've got to say, this was the point that surprised me most. I thought there'd be data being collected, but I hadn't realised quite how much is already being collected every day out there. And I think this quote says a lot. So the sector's evolved to have all these outcomes data coming in, but I don't think there's enough investment in the sector around intelligently using that data or using it in a more collaborative or collective way to achieve change. So the issue isn't that the data's not there, but it's how it's put together and used to shape, inform, and then change certain narratives and to drive change, excuse me. So the second half of the interview, we moved from thinking just about outcomes and how they're being used to thinking around applying this dyadic outcomes approach. And in the conversations with the 25 professionals, I found that some people weren't working in this way, But some people, and particularly social workers, were already adopting this in practice. So depending on the person's experience, we either talked about what they were already doing, or we sort of thought hypothetically, or sort of imagine if you could work in this way. What do you think are the benefits, challenges, and barriers? So first of all, benefits. Professionals spoke a lot about the ability or the benefit of having a holistic view of needs and outcomes, particularly in needs assessment and care planning, but also in other areas as well. If you really have that whole view, you understand not just an individual, but the important people around them, and the way in which that can then be used to guide and to put in the right support at the right time in the right way. There was also mention of the way in which it can build trust between professionals and families. And it also ensures that carers are being put on an equal footing to the person that they're supporting. So they're there at the table in an equal way. But as before, there were a number of challenges and barriers identified. There was some concern around ensuring that carers aren't overlooked. And I think some of this was coming from practice where there was an attempt to try and look dyadically, and noticing that if, for example, funding streams or assessments were done too closely together, there could be a blurring, and that meant that individuals weren't seen as individuals and that particular needs might be easily overlooked. And another area that was highlighted was around workforce and resourcing. It was very clear that understanding outcomes in a dyadic way, particularly in needs assessment and care planning, is highly skilled. It requires experience, it requires time to build those relationships. And those who were adopting it noticed that it was sometimes a struggle to do that. And also managers managing teams of people could see some of the challenges, or also spoke of this particular area being a reason why it doesn't happen sometimes in practice. Other issues identified were around data protection and confidentiality. And this particularly arose in situations where you have organisations, usually carers organisations, outsourced to do needs assessments for carers. And then you would have the person with support needs perhaps being assessed and having care planning done by the local authority. So you've got two separate organisations. And there are certain challenges around what information can you or should you share, how should it be shared, and navigating these issues of confidentiality and data protection. But also sometimes within organisations, these same questions came up. How do you navigate through and work out what's appropriate to share at the right time? And finally, there's what we've put under the umbrella of funding and strategic leadership. A number of people from different perspectives were talking about the way in which both funding models, but also the way in which services are managed and led, can either increase the likelihood of working in a dyadic way or work as a barrier to it. And I think this quote here captures that. So commissioning drives it, doesn't it? How services operate, for sure. So that is, I think, or could be one of the number one challenges. Services are just not set up to work like that. So in some areas, trying to work in this way would really be pushing against the grain of what's already set up and how it's working. So coming then to a summary of what we found in this particular work package and some reflections on it. I think overall we can say that adopting a dyadic quality of life lens is perceived to be beneficial, but there are clearly challenges and barriers to its implementation. Some of the bigger picture questions swirling around in the background include, how are we really meant to understand the role of carers? Quite often, they end up sitting in quite an ambiguous place. They might be viewed as people who need support in their own rights, but sometimes they're almost taken for granted or become invisible. So it's quite a challenge to work out where they should be situated. And a few times it came up in the interviews around perhaps challenging some of the way in which services are designed and delivered. And rather than thinking about people in boxes, so as service users, patients or clients or carers, perhaps thinking more broadly around supporting people and taking a much broader view. But of course, there are challenges in that as well in a kind of resource limited system. So big thought, big question to be discussed. There was also some questions around reframing of needs and outcomes beyond individuals. So not just thinking of an individual carer and an individual that they support, but thinking about them in relationship to each other, which, as I said, a number of people were already doing, particularly social workers. But actually, it's something that's quite complex and takes a lot of skill and time to do well. And finally, there's something about the challenge of trying to take this idea of a dyadic lens and actually making it a reality in a task-focused system with limited resources. So actually acknowledging that. And I think behind all of this, one of the interests I had and something we found was very much around what's counted. I think data collection often shows what we're interested in and what we're looking at. And there's some real questions around why data is being collected and also how it's being used that might challenge us and get us to think a bit more. So finally, just trying to draw out a couple of recommendations. In terms of using and applying outcomes, one recommendation is around who decides what's collected, how it's collected and applied. And I think particularly in the quotes earlier around some of the questions being perceived as not being the right thing, or questions perhaps being seen as intrusive or invasive. There's a question here, I think, around how it's decided what to collect, and some questions around perhaps co-production of a variety of people, including people using services, to help guide and decide what's collected and how it's collected and also how it's used. Also making the best of what data's already there, linking it together, allowing the contextual influences to be considered, and also using a combination both of quantitative numbers data and qualitative data, and also something about tracking over time. So these sorts of questions allowing us to develop a better picture of what's going on and make the best of what's already happening. And finally, that applying dyadic outcomes. I think there's a real potential here to help all of us understand the wider benefit of social care, and also sometimes the unintended negative impacts of social care. And also, I think importantly, it's not just collecting data for the sake of it, but helping us to build a narrative and understanding and to make the case for the need for investment and sustainable care. So again, just to acknowledge the funder and everyone who participated. Also to say thank you to the Centre for Ageing Better for their images that we used in this presentation. And we've also got a written report of this, which people can look at afterwards if they wish to. So I'll just stop slide sharing. Just looking at the time, I think we have a couple of minutes if there are any questions.
Stacey, I've been keeping an eye on the message in the chat, and there are a few questions for you actually. The first one's from Peter, who asks, but tell me if I summarise this wrongly, Peter, that there's a tension between collecting information that might have budgetary implications, and do you want to comment on that? There's almost a kind of default, sort of push to perhaps not collect information that might then have, cost implications.
Yeah, and I can completely appreciate that. There's sometimes certain things that there's an incentive not to collect it, because if it's collected, it might be used in a particular way. And I think this is a sad challenge, but it is a challenge that we have. And I think you can probably tell from the direction of my speaking, I'm hoping that we could move in a direction where there's greater collaboration and use of data in a positive way rather than a punitive way. But I think we do need to acknowledge that we're not there yet. But I do see some signs of momentum questioning the way in which data is used. And I think the more of us aware of that and behind that, making a case for something different, the better.
Then there's a question from Tina, who quite rightly observes that it never ceases to amaze her, and actually most of us, I think, that outcomes are about the here and now and never look to sort of future-proof couples care, or indeed anybody's really, to look at the use of LPAs or to consider care choices in the future. So I just wonder if you wanted to comment on that then.
Yeah, and I think that's a really good point. So often we are so focused on now, and yet we know that situations flux and change. So with the outcomes measure that I've used quite a lot, the Adult Social Care Outcomes Toolkit, or ASCOT, that can be used in flexible conversations to get people not just to talk about here and now, but begin to think about what if scenarios. And of course, you can't predict exactly what's going to happen, but that what if scenario, certainly when I've used it, and I know other people have, it can open up conversations in a way that you can begin to move into that territory. So I think that method, the ASCOT method, is something that has potential to be used in that way. And I'm sure there are other tools out there as well.
Tina's also asked a second question. I'll come back to Gillian's in a moment. Again, it's a sort of question about what's collected and what drives what's collected. And her observation is that it seems to me there is a politics to data collection influenced by the Care Act domains, restricting what is collected and what is used as a means to manage resources. So it's a bit of Peter's question as well, actually.
Yeah, and I think, again, that's what I was hinting at with the suggestion or recommendation around co-production. So there's something about, if we can, try and open up the conversation and get people involved who are involved in collecting and also producing the data, and trying to get their views about what matters and why. Personally, I think the Care Act definitions are helpful. They try and keep a broader view of what care is doing. And I think they include some areas that would be very easy to kind of overlook or forget. But I don't think they're comprehensive, and it depends on the type of service or the area you're working in. And what I can say is that the people I spoke to, there was a range. Some people felt that what they were collecting was really useful, and other people felt there was a huge mismatch. And I think having an awareness, if you're in a mismatch situation, of being able to try and have some conversations to shape what's being collected, that's a good thing. And like I say, the Care Act, I think, is a basis, a starting point, but shouldn't be the extent of what's collected.
Gillian asks a question about interviewing carers, which wasn't the focus of Work Package 2, that was professionals, but we'll be moving on to Work Package 3 in a moment, Gillian, if that's all right. She asks about, did you interview any carers to find out whether this approach to using outcomes filters down to service provision? So I think that's probably a Work Package 3 question. Hang on a second. Gail asks, can you share which outcome measures were used by interviewees?
So yes, the sorts of measures that were included were the Warwick Edinburgh Mental Wellbeing Scale. There was also General Quality of Life Measure, the WHO, and then a number of them actually used bespoke measures that they developed in-house. So there was an incredible amount of fragmentation. It was almost like each organisation had come up with their own questionnaire. And as someone who, in part of my work, I develop questionnaires, there's a number of those off-the-peg questionnaires already available. And I found it really interesting that people weren't going to those, they were actually making up their own. And actually there being a lot of activity. And that question, again, when I was talking about co-production, part of that could be looking at what's already out there and then working with people to decide whether any of those could be used off the peg rather than designing your own each time.
And then a question by Debbie, good, interesting question. How did the research take into consideration the needs of older carers from ethnic minorities?
Really good question. So this came up as one of the sort of sub-themes, and their particular needs were highlighted along with other groups, so LGBT+, carers of people with stigmatized conditions, parent carers of people with learning disabilities. And hearing from services, it feels like there's an increased awareness that carers are not a homogenous group and there are different needs. And particularly what came out in our interviews was around social support and being able to provide spaces where everyone felt welcome and safe, which for certain groups sadly isn't always the case.
those, I think, oh no, hang on a moment. Yes, well, Peter's just making a sensible observation, which I think we'd all agree with, that, you know, that sometimes it's a challenge to collect information. It doesn't always help, because we do think about that outcome for getting the person's needs today. So there is a sort of balance, isn't there, between the now and the future, and it's a challenge, isn't it? Any other questions from, I can't see any hands raised, but if anyone's got a question. Oh yes, no, that's just me imagining it. No, don't think so. Okay, great. Thank you very much, Stacey.
Great, thank you, Alison. So we're coming now to the third and final of the presentation. So I'll be handing over to my colleagues, Grace and Barbara.
Afternoon, everyone. I will just share my screen. Can everyone see that okay? Okay. So myself and my colleague Barbara will be covering Wet Package 3 today. So Wet Package 3 was focused on the qualitative interviews with older carers, so those aged 65 or over, and the people they support. So our aims of this work package were to understand the quality of life of older carers and the people they support on an individual and a dyadic level, so also together as a pair. We wanted to understand the role of services in quality of life of older carers and the people they support on an individual and dyadic level as well. So our methods for this work package were semi-structured interviews, and in these interviews we firstly began by asking the carer and the person they were supporting about their use of community-based services, so how they might have found out about the services they used, who funds it, have they received an assessment, and then we would also ask about their everyday experiences. So carers and those receiving support have slightly different areas of quality of life that we ask about. And this is based on previous research from the Adult Social Care Outcomes Toolkit that has found social care impacts on different areas, depending on whether you're a carer or a person being supported, or even based on different services. So for instance, for carers in these interviews, we asked about their occupations, so what they do with their time, their control over daily life, their social contact with people, their safety, both inside the house and outside the house, their self-care, so have they got an opportunity to look after themselves, such as sleeping well or eating well, time and space to be themselves, and also feeling supported and encouraged to keep caring. Whereas for the person being cared for, we asked about their food and drink, their home cleanliness and comfort, their personal cleanliness and comfort, their control over daily living, their occupation, so what they like to do with their time, their social contact, their personal safety, again, both inside and outside the home, and also dignity, if they are receiving help from staff or from volunteers. So for each of these, we then also talked about whether the community-based support they were receiving made a difference in their lives, and if it had made a difference, how that was having an effect. We would also ask what it would be like if they didn't have that support. And then also, if they did indicate that there were some unmet needs in that area and the services weren't necessarily helping in that area, we would ask them what may help. So for participants in this study, our eligibility criteria was that the carer and the person they were supporting lived together, and the carer was aged 65 years or over. So the person being supported didn't have to be over 65. They had to use at least one type of social community-based service. This could be day centres, help coming into the home, but also things like Meals on Wheels or changes around the home, such as handrails. They had to be able to consent and able to engage in interviews in English, and they had to live in England. We decided at the beginning of the study that carers could take part on their own. This was because we didn't want to exclude carers based on the fact the person they were supporting didn't want to take part part or couldn't take part. And this was always quite a high risk with the group that we were looking at. We decided carers could still provide us with a wealth of information that we needed, and we also knew it wasn't going to be easy recruiting pairs. So we began our recruitment of participants using two main methods. We actually joined the website Join Dementia Research, which is a website that connects registered volunteers with dementia researchers across the UK who are looking for people to join their studies. So anyone who's interested in dementia can sign up to Join Dementia Research. But if you do register a project as a researcher, you can filter criteria that you may have. For example, you could say that you only need people who have a diagnosis of dementia. We also used our connections, including our project advisory group, to have help from the adult social care community-based services, who offer to hand out information for us. So Join Dementia Research had 560 carers and 360 people living with dementia who may be eligible for our study. We gave packs to the community services that said they'd help and the local authorities, but we don't have numbers for how many that potentially could have been invited. In total, we looked at 537 carers and 357 people living with dementia via the Joint Dementia Research website. This was via their preferred method of communication, so either email or post. If they were contacted by email, we'd send one more follow-up if we hadn't heard anything within 4 weeks. Adult social care services handed out the packs for us that included things like the information sheet and consent forms. And again, we didn't ask how many that they had handed out. So on JDR, we found 358 carers and 288 people living with dementia that met the eligibility criteria. And 2 pairs of people came forward from where they've been contacted via the adult social care services. So in the end, we interviewed 17 carers and 9 pairs, and 2 from the social care community-based services, so 2 pairs. And our analysis in total was 29 carers and 11 people with support needs. And this recruitment process went on from April to December. It was quite a long process just because we had to have lots of initial conversations with carers to see if they were eligible, check that what community-based services they were receiving, and go through that first before they were then invited to interview. So I will now pass over to my colleague Barbara, who will go over the results.
Thank you, Grace, and we can move to the next slide. Thank you. So on average, the carers that we spoke to were 75 years old, and approximately half of them were women. And the majority of the carers that we spoke to cared for their spouse or partner and provided 50+ hours per week of care. And on average, the person they supported was 75 years old and lived with dementia. And I would like to highlight 3 things about our participants, just when we will be thinking about the results and the implication of the results. Firstly, majority of the carers we spoke to were white or white British. Also, none of the participants self-identified themselves as from LGBTQ+ community. And when thinking about the results and its implications, it's important to know that 2/3 of participants paid for their social care services themselves, either in full or a contribution. Next, please. So on this slide, we can see the range of adult social care services our participants accessed when we asked them about the services they used in the last 12 months. And also whether the services that they accessed met their needs across different areas of their quality of life that were earlier mentioned by Grace. So for example, carers and the people they support most often access things like support from carers organization, then information and advice, and also services allowing them break from caring, but also equipment or adaptation to the home. And it's quite important to know that even though people access a range of adult social care services, their needs across different areas of their lives were not fully met. So for example, carers felt some level of unmet needs across their control over their daily life, things like being able to do things that they value and enjoy, and also having time and space for themselves. And importantly, carers actually felt that they were not fully supported and encouraged by adult social care services in their caring role. So really the key takeaway message here is that while people may have access to adult social care services, their needs still remain not fully met across different areas of their lives. Next, please. So, of course, in these interviews, we were interested more in depth to find out what are actually day-to-day experiences of all the carers and the people they support, about their experiences with adult social care services, how their needs are met, and what are the potential gaps that can be improved. And based on these conversations, we recommended 34 recommendations. How basically things can be improved across different areas of people's lives. And we grouped these recommendations for unpaid carers, then family, friends, neighbors, but also local authorities and community-based adult social care services. I will not go into detail about these key recommendations. If anyone is interested, please get in touch and we will share this with you. But I would like to highlight two key things. It goes without saying that if there is not adequate funding in place, it's quite difficult then to meet all the other recommendations. So once this lack of adequate funding is removed, it can have potentially like a positive spillover impact on other recommendations. And quite interestingly, even though we did not ask our participants about healthcare services, they spoke about it a lot. And actually, one important finding was that healthcare services can facilitate the access and support for all the carers when it comes to the provision of adult social care services. Thank you. Next. So when thinking, all the carers and people that they support are thinking about the type and intensity of support needed, they made quite complex decisions around this, and they face several dilemmas when it comes to these decisions. So just to illustrate this point, when carers are making decisions what the type and intensity of support is needed, they would take into account the needs of the other person, what would benefit to them, but also what finances are available to them to pay for these services. And these decisions are even becoming more complicated when there's a discrepancy between the needs of the carer and the individual they support, when there is a hesitancy of allowing a stranger to come to your house, when the person with support needs may have an additional communication need. So for example, the person with support needs is unable to tell us what they need, how they feel, etc. And actually extra support may potentially result in spending less time together. Next, please. So I think, as we heard already from Wenjing, it's not surprising, I think, to us that indeed caring is a function of relationship, and these relationships are complex, and it also then impacts how these decisions are made around the type of community of support needed and how the dilemmas are faced or dealt with. And it's important to know that carers decide to care for the other person for different reasons, but as the caring needs are increasing, then also the dynamic of the relationship is changing. And usually it's described by both the carer and by the person supported as a one-way street. So carers are experiencing emotional support from the other person and also the person themselves. And on the other hand, the carers, the person with the support needs are aware of this, that they are becoming more and more dependent on the other person. Next, please. And quite important finding when we spoke to other participants and the people they supported, and a lot of recommendations that we put forward for adult social care services was around the routine. And I just want to bring again that information that we spoke mostly to carers who support someone living with dementia or to people who live with dementia. So for people living with dementia is extremely important. Any deviations from routines are experienced as very distressing. And this is something what carers are often aware of, and they really try to minimize any distress for their loved ones. And what it meant then that carers just felt they couldn't really live their life spontaneously. Often they would do things that just for themselves when the other person wanted to sleep, or for example, when there was indeed a support from adult social care services or others. And interestingly, carers also mentioned to us the use of technologies such Amazon Echo or iPads to basically help with entertainment for the person they supported. And just to illustrate this point of routine and how it can be perceived by different people, I would read for you two quotes. This was a couple. They were interviewed separately. And the male supported by his wife told us, well, I have my routines and I follow my routines. There's a routine and yeah, I'm not being told to do anything or forced. And on the other hand, his wife experienced it as this. What I'm doing now is my new norm. While he's lying down and resting, recovering from that, I won't do anything that makes a noise. Next, please. And finally, even though we did not ask about the impact of COVID, this definitely came out in conversation. And I think this is also important to again highlight, and Grace spoke about it. We collected data back from April 2021 until December 2021. And what it meant is that back in April, some of the restrictions started to be lifted. So for example, we could go to get our haircut or just meet outside in the pub. But by the end of December, all the restrictions were lifted. So the information that we collected over the time could quite change. And the key findings that we all know from other evidence were that carers, older carers and the people they supported felt quite abandoned during this time. They felt very much isolated. And also a lot of adult social care services, as we know, stopped during the time or their provision changed. And often this was not seen as a suitable, not for everyone, but some people were clearly saying to us, well, having a Zoom meeting for a person with dementia, that's not going to work. But for me, I think the key finding here was just as a reminder how really a life, day-to-day life can look like for many older carers, is that they were saying, well, when the full restrictions were in place, we actually felt that it leveled up the field. So carers were saying, well, it's horrible things to say, but at least we are in the same boat. We cannot can go out. No one else can go out. Next, please. And just to summarize, so the aim of this study was really to understand what are the experiences of all the carers and the people they support, and what's the role of adult social care services in their quality of life, both at individual and dyadic level. And the key findings, I think, and recommendations are that even though there are adult social care services available, people's needs are still not fully met across different areas of their lives. And as you heard, we suggested 34 recommendations. And I think it was and all these recommendations are based what all the carers and the people that they support shared with us. And this is such a, I think, powerful reminder that all the carers and the people they support are experts on what works or not and how to improve things. And for example, there will be recommendations around co-producing the assessment, co-productions of provision of services, etc. And I think it's also quite important to remember that caring is a function of relationships. As any relationships, they are very complex, and people have to make very complex decisions when it comes to deciding what type of services and intensity of the services is needed. Next, please. So this is the mandatory disclaimer. And last slide. Yes, thanks so much for your attention. And if you have any questions, feel free to ask now, but also feel free to follow up with me and Grace at any time point if you would like more information on anything what was shared today.
Okay, thank you, Barbara and Grace. So as you've been speaking, there have been quite a few questions coming in through the comments, which I'll go through. If other people have questions, do add them or put up your hand. So the first question we had from Peter, he wondered whether in the interviews, were people asked, so if they said that they didn't ask for help, were they asked or did they explain why they didn't ask for the help that they needed? Were they thinking about cost, or was it a lack of trust in the system? Was there any insight into the reasons why?
Do you want to go, Barbara? Should I? I think some of it, from what I remember, is that when we asked people, is there anything that could help this situation or not, a lot of them couldn't think of anything that could help, which I think is also a lack of information that they received that might be available. It might be that they felt what they would be asking would be too much. For instance, more care, which would be more money, more funding, whether that was self-funded or whether they were getting it funded for. But for some people, Barbara, you can correct me, I felt that some of them just didn't know what could help. Whether what they were experiencing they felt wasn't really helpable, or whether they didn't know if any service was out there that could benefit them in that area of their life. Do you agree, Barbara?
Yes, I agree with that. And actually one of the things, so indeed this was raised by carers, but also the people they supported. Well, they didn't know what's available out there, but also they even couldn't imagine whether it would make any difference to them. So therefore, some of the carers, what they were highlighting is actually that speaking to other carers was helpful to them, because they could hear from people with the same experiences, like, oh, this is what helped me, this is how it helped me. If you experience this, you have to get that. But I just want to highlight, like, we didn't really come across that much that people didn't ask for help. People were asking for help. It's just about more that the help wasn't available. And I didn't go into detail about this. And of course, let's put it in the context of the pandemic and etc. But people were not even getting assessments to begin with. If they got assessments, then now speaking about cares, it was mostly focusing on the person with support needs. If they got assessments, there was no follow-up. Yeah, and also people were speaking about things like, well, it seems like it's a postcode lottery. It seems like depending where you live, you will get a different type of support and help. So yeah, yeah, I think it's just go mostly back to like, well, is there even help available to them? And if yes, is that even suitable?
There were a couple of questions from people around the sample. And Barbara, you did mention this, the sample is mostly people, carers of people with dementia. So the question was around why was the sample quite like that? And also whether we think that the findings would transfer across to other groups of carers.
So just to answer the first question, it simply goes back to how we collected the data. So most of our carers came from Joint Dementia Research, which is a platform specifically for people interested in dementia. So that was one of the reasons. And of course, this wasn't planned to begin with. We hope to get as variety of carers as possible, but we struggled with the data collection so much. We basically, as Grace mentioned, we did engage with 10 different adult social care organizations, but only 2 pairs came forward. So it's really reflects, it wasn't intentional, it just simply reflects the way how we ended up to collect the data. And to answer the second question, no, I think let's remember, this is a qualitative study. When we are getting an insight about this particular population that we spoke to. So I think it would be, so no, I would not make any, just based on this data, I would not make any recommendations for different groups. Saying that, of course, there can be an evidence base, for example, of carers with other chronic conditions that can be very similar to what we find out. So it's definitely important to look across the evidence.
Okay, thank you. And then there were a couple of questions around needs. So the question was, how did you define carer needs? It seems that this would be difficult not to include health-related needs, yet you didn't ask about the experience of healthcare. So I hope it's okay if I just sort of very briefly say, I think we acknowledge that we're funded by the School for Social Care Research. So we were coming very much with a kind of primarily social care focus. And certainly when we're thinking around social care, when we're thinking around needs, they're often needs related to well-being or quality of life outcomes. So we're thinking with a Care Act frame. So we're thinking of well-being outcome needs to do with social relationships, a clean and comfortable home that's habitable, being able to maintain nutrition, these kinds of things. And we had a comment also from Joanne, who was saying she's from an occupational therapy background and said that the language we were using resonates. So I think that's kind of acknowledging that, yes, that's the lens we're coming from. But just to hand over to Barbara, because I think health-related needs and the questions around that did come up spontaneously.
Yeah, they definitely did come up spontaneously. And of course, it would be good to understand what exactly we mean by healthcare needs. So the way how it came up was mostly, and please Grace chip in, it was simply when we were speaking about, where do you get your support? You know, how did you find out about the adult social care services? Take us back to the beginning, etc. And then people would kind of spontaneously start to talk, well, you know, just I'm thinking about my GP, I'm talking about this clinician, I'm thinking about this person. And there were a few things happening there. And I think it goes back how we think about these things, like in complete separation. We think about adult social care and then we think about healthcare, and it's completely separated, but it's obviously not. And firstly, people were saying, well, there seems to be a lack of awareness of dementia between healthcare professionals, just to begin with. Or there seems to be also lack of awareness of what is it like to be an unpaid carer. So, for example, community-based adult social care services could provide some training around that to, for example, GP surgeries, etc. But also, quite interestingly, when there was an awareness of adult social care services, it was actually often the GP or the clinician or the consultant who stepped in and recognized that someone is a carer and they needed additional support. So I know it not exactly answers this question about healthcare needs, but I think it tells us a little bit more about how we separate things, and maybe it would be far more beneficial if we start to think about how these two, healthcare and adult social care, can truly come together and support the people in their lives.
Okay, thank you. We've got a couple of other questions here. So one around the findings to do with COVID, and that idea of COVID as being a levelling out field, so that carers were sort of saying to other people, now welcome to my world, you're now experiencing what things are like. And it sounds like that's also being found in other studies. I don't know if either of you want to add anything there.
No, I would just say, like, from my personal point of view, like, it was such a powerful thing. Just, you know, for me personally, when COVID started, it was such a drastic change to my lifestyle. But that's basically how many carers, how their day-to-day life looks like. And I think it's even, yeah, it's so inspiring just to truly, I think, try for us as a research team to hopefully make some difference in their lives.
So thank you so much for the questions. I'm aware we're coming now into the final 10 minutes. So I'm going to hand over to Alison, who's going to give some brief reflections and bring things to a close. Thank you.
Thank you very much, Stacey. I'm just going to sort of gallop through a few what I call kind of key messages, headline issues, and then if there's time, a couple of reflections. So I think it's important to acknowledge that older carers and the people they support are still a rather hidden population and a growing population. We've already heard about that for a range of reasons, often in part because the carer themselves doesn't view themselves as a carer. They often see themselves as a husband or a parent, or in other words, the concept of care is not something they easily identify with, even if in fact they're doing a great deal of caring. It's sort of a no-brainer in some ways, isn't it, to think that the quality of life of the carer and the cared for person are intertwined. Hence the need to consider assessing needs and providing care that takes account of the dyadic nature of the relationship and of living. People live together in that relationship, rather than the current model, which tends to view people in individualized silos. So you've got the person with care and support needs, and the carer often viewed, services commissioned separately and assessments done separately. Research in this field is limited, as we know. There is also some evidence that the Dyadic approach is being recognised by care providers and by practitioners, but it's not embedded, it's not normal, it's not ordinary part of the system, not yet anyway. Although social care practitioners recognise that there may be some benefits to capturing individual outcomes, there is a strong view that applying a dyadic perspective, a dyadic outcomes approach, will reap greater benefits in terms of gaining a holistic view of needs and outcomes in context, help to build trust relationships between staff, professionals, families, and potentially places carers and the person they care for on an equal footing. But applying a dyadic lens does take more time. It's a skilled activity, demands that the current system, for example, commissioning arrangements, change, and requires a new and different way of framing and capturing practice-related outcomes. For example, improved well-being of the dyad. There is a need to rethink current systems. Can it be done in a way that includes the perspectives of users and carers, and to produce sustainable improvements in well-being and quality of life outcomes? And in terms of research, it is challenging to adopt a dyadic approach regarding the impact of social care services on quality of life. People who receive social care services often have complex needs. Services interleave with a number of different areas of users and carers' lives. Untangling impact is a challenge. As noted already, caring is embedded in often long-term, lifelong in many cases, relationship. So viewing it as situated outside of that relationship fits ill with how people live relationally, practically, and emotionally. Carers and people with care and support needs know what works for them and what does not. In essence, there are sort of three sets of needs and outcomes: people with care and support needs, carers, and the care dyad. Research is in its early stages. And in terms of reflections, I'll literally reduce it to two, Stacey, because I'm aware of time. I think the practice world and the research community need to work together to do better around the whole dyadic discussion and dyadic outcomes, and how you capture those outcomes meaningfully. And a key part of this will be listening to people who use services and their family carers. It just won't work without that. I think we need to encourage social care practitioners, and we've heard today that some social workers in particular are already employing and thinking about dyadic approaches to their practice. But it does require a system change. Commissioning, we keep saying this, but services for carers and people with care and support services are often commissioned separately, assessments are done separately. So for this to become normal, embedded in the system, which I think most of us agree makes sense, it does require change to come from the top, not just at the front line of practice. So it's a bigger quest than that. I think that'll do. Is that all right, Stacey? I could carry on.
Oh, I'm sorry.
If you know me now, I could carry on.
Oh, no, wonderful. Thank you for very nicely summarising. There's lots of positive comments appearing, but a wonderful summary of the projects and highlighting those kind of key recommendations. I'm just looking, because I think there might be actually a question coming back. So from Richard, great summary, Alison. Some really interesting presentations too, and much to think about. It's still clear to me how much more research and evidence we need, and I think that's something that we'd all agree with. And then also highlight something about the carers being very heterogeneous, and that even with subgroups such as over 65s, they're not a homogenous group. And I think we would all nod. And I've got to say that that was actually one of the sub-themes that came out, that we really can't be thinking of groups, even if we try and break them down to make it a little easier, there's great diversity. So I think we're pointing together all in the same direction. So I suppose at this point, just to really say thank you so much to everyone who's participated, who's come along today and contributed. If you want to follow up and to hear more, we'll be in touch with the slides. Do send us an email or be in touch by other means. And also just to say a huge thank you to the project team, everyone who's presented today, including Helen Ramsbottom and Della, who are our PPI research advisors who didn't speak but very much part of the project team. And also just to say thank you to everyone who came along, everyone who participated. And if you do want to continue the conversation, do be in touch. Thank you very much, everyone. Thank you.
Thank you. Bye, everyone.